On April 15, 2025, Sage Therapeutics withdrew their postpartum depression breakthrough, IV Brexanolone, from the U.S. market. Today, we look at what was lost and what to do without it.
Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue.
We launched the first Carlat podcast in May of 2019, just 2 months after the FDA approved Brexanolone, Zurzuvae, as the first medication for postpartum depression. 6 years later, the manufacturer withdrew Brexanolone to focus on its oral version, zuranolone, Zurzuvae. However, these two medications are different. Brexanolone is intravenous, and zuranolone is oral, and that means different plasma levels and a potentially different effect size. Today, I'm going to explore this drug and its oral cousin, starting with what's lost in the transition: potency. In terms of potency, IV Brexanolone had a very large effect size, 1.2, while oral zuranolone's effect size was only moderate, 0.5. An effect size of 1.2 is remarkable. Very few treatments in psychiatry rise above 1.0, among them ECT and IV ketamine. Yes, I said IV ketamine. The IV version of ketamine has an effect size that's actually similar to Brexanolone's, 1.2, but its effect falls to 0.3 when we use the intranasal version, S-ketamine Spravato. IV medications are more common in Europe, where inpatient psychiatrists have long used IV valproate for mania and mixed states, and IV citalopram for depression. Anecdotally, these psychiatrists tell me they get better results with the IV drug. Sage Therapeutics' decision to withdraw IV Brexanolone last April was purely a business one. The drug faced many obstacles in the U.S. It requires a 60-hour intravenous infusion and a REMS program, and it has to be delivered in a certified healthcare setting. Both zuranolone and Brexanolone are sedating, but the IV version caused some women to pass out, so they need to be monitored during those 60 hours. And IV was expensive, $34,000 just for the drug, not to mention the hospital care. The fact that it was released just a few months before COVID lockdown also added to its woes. All in all, just over 1,000 women actually received the IV drug. With all of those challenges, Sage Therapeutics developed the oral formulation, zuranolone, which the FDA approved for postpartum depression in 2023. Brexanolone is administered intravenously over 60 hours, while zuranolone is taken nightly for 2 weeks. While not as powerful as Brexanolone, it still offers many of its advantages for postpartum depression. For example, it delivers results within 3 days, which is crucial for postpartum depression, where each day of symptoms takes a measurable toll on infant health. Zuranolone addresses one of the underlying causes of postpartum depression, the drop in neurohormones, particularly allopregnanolone. Zuranolone is a synthetic analog of allopregnanolone. And zuranolone, though not as potent as Brexanolone, still has a larger effect size than the SSRIs at 0.5 versus 0.3, and both those numbers are in postpartum depression. And it probably means zuranolone is more powerful than the SSRIs, but we can't say for sure as the two have never been compared head-to-head. For many years, SSRIs were the go-to for postpartum depression, particularly sertraline, Zoloft, which has a favorable safety profile in breastfeeding. Zuranolone's safety during breastfeeding is unclear, so women should avoid breastfeeding while on it. However, they can pump milk and discard it during the 2-week treatment in order to maintain their lactation ability. Now that we've said goodbye to Brexanolone, let's take a closer look at its replacement, zuranolone. Zuranolone works quickly, within 3 days, and those improvements persist throughout the 14-day course of treatment. Those benefits do start to decline about a month after stopping it, and we don't know what happens beyond that, as 1 month is the longest follow-up period. The postpartum trials for zuranolone enrolled women whose depression started as early as the 3rd trimester or as late as 1 month past childbirth. Wait a minute. Can postpartum depression start before delivery? Yes, it does. In fact, in DSM, it is no longer called postpartum depression. It's peripartum depression, and the onset can be any time during pregnancy and up to 1 month after delivery. However, zuranolone is not considered safe in pregnancy and was not started then, even if the depression began during pregnancy. By the way, ICD-11 stretches the postpartum cutoff a little longer, up to 6 weeks after delivery, and for most women, the peak of onset is around 2 weeks after delivery. The women in the zuranolone trials were like most women. 63% of them had depression that began somewhere in the first month after delivery. Even though the trial required depression to start before a month after delivery, that doesn't mean that zuranolone was started then. Delays in care are the norm here. In a recent study, only 1 in 10 women who were referred for postpartum depression actually made it to that mental health appointment. In the zuranolone trials, women had to be within a year of childbirth to start the medication, and the episode again had to start in the 1st trimester or within a month after delivery. So that is the ideal candidate for this drug. For most women in these trials, the postpartum episode was their first episode of depression, though a small minority, 14%, had recurrent depression. This matters because this is a rapid-acting treatment that tapers off, so we're going to need something more to keep people well if their depression is recurrent. None of the women in these trials had suicidality, psychosis, bipolar disorder, or recent substance use disorders. Those were all excluded, and in this podcast series, we're going to dive more into those and see what we can do for them. Hint, it's not going to be zuranolone. So we have a limited population here where zuranolone is the right fit, but this medication is still a game changer. I'll get to why I think that more in the next episode, but first let me explain just how limited its use is. Zuranolone does not work in non-postpartum depression. The company tried to get it approved there, but failed. They've also tried it in PTSD, premenstrual dysphoria, tinnitus, and insomnia. And I'm not sure where the investigations stand on all those conditions. But let's get to regular depression, where you don't want to use it for non-postpartum regular depression. There, zuranolone is probably no better than a benzo. It brings some quick relief, but fades away after just a few days. Actually, the benzos look better than that. Alprazolam's benefits in depression lasted up to a month in its trials. That's right. Alprazolam treated not just anxiety, but core symptoms of depression in over a dozen short-term trials. I repeat, short-term. The company tried to get alprazolam approved as an antidepressant in the 1970s, but the FDA wouldn't have it. They were worried about its abuse liability, and possibly about the fact that benzos can cause depression with long-term use. Today's FDA is a bit more liberal, as esketamine's approval shows, and they might have approved zuranolone too for regular depression, but with the trials only showing 3 days of relief, that was not enough.
Let's pause for a preview of the CME quiz for this episode. Earn CME for each episode through the link in the show notes. 1. What is the difference between Brexanolone and zuranolone? A. Brexanolone is delivered intranasally while zuranolone is oral. B. Brexanolone has a smaller effect size. C. Brexanolone is more sedating and causes patients to pass out. D. Brexanolone is not a controlled substance.
Zuranolone is scheduled as a controlled drug, just like the benzos, and I think of it as a neurosteroid version of the benzos. It modulates the same GABA receptor, though it attaches in different ways, and that its clinical effects are comparable to those of benzos. It quickly treats anxiety and insomnia. In studies of recreational sedative users, zuranolone had a similar feel and elicited similar drug liking as a benzo. It's possible that zuranolone works in postpartum depression but not in regular depression because it addresses a known part of the pathology there, the sudden fall in allopregnanolone that occurs after delivery and destabilizes GABAergic transmission. That possibility is exciting because it's one of the first times that a psychiatric medication was arrived at by following a theory rather than happenstance. And if that theory is correct, there is one postpartum scenario where you may want to avoid zuranolone or at least use it with caution. Although the drop in allopregnanolone triggers postpartum depression, biology is complex, and some women become depressed when allopregnanolone rises back. When does allopregnanolone rise back? When they stop breastfeeding and resume menstruation. There are studies that link this post-breastfeeding depression to the rise in allopregnanolone, so it may not be a good idea to add more fuel to the fire with zuranolone in those cases. Next week, I'll look at the hidden reason that makes zuranolone a game changer for postpartum depression. Hint, it has to do with bipolar disorder.
Like the podcast? Share it with a friend. Use the arrow button in your podcast player, or write us a review. We read every one of them. And if you have topics you'd like to hear about, let us know at asktheeditor@thecarlatreport.com. The Carlat Report is one of the few CME publications that depends entirely on subscribers. Thank you for helping us stay free of commercial support.